Okay, welcome everyone to our 15th Ian's Patient Seminar Series, Living with and Talking About Serious Illness with Dr. Emily Rivet and Dr. Donna Newmark. Uh, just some housekeeping rules. Try to keep your videos off and stay muted. If you have questions or comments, there'll be time at the end, and please put them in the chat as we go along. And this will be recorded, so you are able to watch it later or ask or to have other people who might find this useful watch it at their convenience. And this is not meant to be intended for medical advice. Just, as the usual, seek your guidance from your medical or healthcare providers before undertaking any new healthcare regimen. So first I'll introduce Donna. After decades of working as an oncology nurse, including several years in the anal neoplasia clinic at UCSF, Donna began a private practice as an end-of-life doula. Her philosophy of care is rooted in helping people experience a meaningful life as they are facing death. Her compassionate guidance is rooted in the understanding of family structure and legacy and years of caring for people with serious illness and their families. Donna is deeply interested in helping people at all stages of life become more comfortable talking about death, encouraging intergenerational conversations about value-based decision-making and advanced directives, and supporting others through loss, post-death rituals, grief, and bereavement. She grew up in suburban Milwaukee before eventually finding her way to the Bay Area. She enjoys singing, dancing, traveling, looking at the ocean, playing Scrabble, mahjong, and pickleball, and spending time with her family and her cats. And we never know, cats may show up in the video if they decide they want to be with Donna. And Emily Rivet is an associate professor of surgery and internal medicine at Virginia Commonwealth University, where she serves as serious illness quality director and perioperative surgical quality director. She is nationally recognized for her expertise in communication skills, training, and quality improvement for patients with serious and life-limiting illness. Dr. Rivet leads multiple cross-disciplinary initiatives, including the VCU Health Serious Illness Communication Project in collaboration with the
Ariadne
labs. Her research interests include cancer prevention, patient engagement, and equity in screening and treatment for anal and colorectal disease. Dr. Rivet helped to create the fundamentals of communication in surgery curriculum, which is being piloted this year in 10 surgical residency programs across the United States. She previously served as co-chair of the American College of Surgeons Surgical Palliative Care Committee and continues to play a national leadership role in improving communication and quality for serious illness and vulnerable patients. So thank you, and I will turn it over to you two.
Well, you're muted, Donna.
Okay. Thank you so much for having me here today. I'm really honored to be speaking to this group. I was actually at the first Ian's conference and presented a poster at that conference. It was, 15 years ago or so. So before we start, I just want everybody to take a deep breath, bring us all into the room together, bring us all into this topic that sometimes brings up a lot of feelings for people. And I'm going to share my slides. Okay, so this weekend is Dia de los Muertos, and I'm not meaning it as any kind of cultural appropriation, but it's a beautiful holiday, and in this picture here, you see two home altars to honor and welcome back the souls of deceased loved ones. And I think at this time of the year, I live in San Francisco, and we have a huge Hispanic population, and you see a lot of celebration happening this week around this. This talk today is dedicated for all those who have died from anal cancer and related complications, and for all those we want to remember. So our talk today is about living with and talking about serious illness. And as Mary Jo said, I'm an end-of-life doula, and Emily is a physician. We're going to be looking at this topic from a couple different angles, that means. And I just want to preface it. I call myself an end-of-life doula, not a death doula. You might have heard of death doulas or end-of-life doulas, but I do that because I like to meet people upstream. I like to have these conversations way ahead of before people are really facing the end of their life. So we're going to talk today I'm going to start with some stigma and symptoms and survivorship issues. Then we're going to switch to Emily, and she's going to bring us the doctor's perspective. And then we're going to come back to me, and I'm going to talk about planning for the future, advanced directives, and what matters most. The work that I do is very values-based. It's not within a medical system. So you'll see what that looks like in a little while, and then we will have time for questions. If you have any questions, put them in the chat and someone can let us know. Sometimes, even if I stand in the middle of the room, no one acknowledges me. So what does that elephant represent? It could represent so many different things. In this case, we're calling it the diagnosis of anal cancer. What happens? What was your first thought when you heard the diagnosis of anal cancer? And I recognize that not everybody on the Zoom is an anal cancer patient, but I'm assuming that many of you are, or you work with or have family members who have been diagnosed with anal cancer. What was your first thought when you heard it? So this was an article that I just found yesterday. Thank you to Google, by a group of doctors in Europe, mostly Italian, who did a qualitative study about patients' perspectives in anal care. It was really a good article if you haven't had a chance to see it yet. And they talk about the interviews that they've had with patients in reporting their experiences across the anal cancer trajectory. The sorts of things that they see at diagnosis, the emotional distress, fear, stigma, psychological trauma, and then just the symptoms from the disease. While you're undergoing treatment for anal cancer, all of the acute side effects, skin issues, bowel issues, pain, fatigue, and many more symptoms as well. And then again, psychosocial distress, how to be with people, how to tell people, how to move through your life. And then in the follow-up period, all the long-term effects, the long-term toxicities that you might have to deal with if you've undergone treatment for anal cancer, as well as any kind of long-term emotional distress, fear of recurrence, and ways to get back into your life in ways that might be different from how you might have been before you were diagnosed. So words matter. You know, there were so many things that we're talking about what people are, somebody who has had a diagnosis of cancer, what are you called then? Are you a person with cancer? Are you a cancer patient? Somebody said, I'm alive, just call me alive. We've heard a lot about, you know, the warriors and the war against cancer and all of that, a cancer rebel. Some people don't like that terminology. A person in the literature and in the medical field, mostly a person is considered a cancer survivor from the time of diagnosis through the rest of life. So if you're going to have any follow-up after you've had a cancer diagnosis, it's often in something like a survivorship clinic. There's survivorship care plans, and I'm going to talk about that next. Some people want to be called thrivers. What I believe in all of this is everyone gets to choose. You get to choose what you want to be called. You get to choose what you want to call yourself. You get to choose if you want to use any of these terms. It's all, there's so many different ways to be called. I've heard more and more that some people want to be called thrivers, and even on the Anal Cancer Foundation site, and on one other, I think Cure, they have articles and blogs about cancer thrivers. So people who are living and what they consider in their life to be thriving. And then there's other people who don't feel that they're thriving. So words matter, but you get to choose. So people assume that when treatment is finished, cancer is finished. Like you said, oh, you're cured, or whether you have to go the 5 years to get a cure, or however, whatever the terminology is. But as you know better than most people, after you've had treatment, the cancer and the effects of the cancer might still be with you for the rest of your life. So these are the components of a survivorship care plan, and they have things like the American Society of Clinical Oncology and the National Cancer Institute. They have websites where you can plug in your cancer type, and they will give you guidelines for what sort of follow-up care that you need. In the drop-down menu, anal cancer is not one of the choices. So I was interested to learn that it wasn't one of the choices. So it's very specific, and I'd love to hear from Emily what sort of, if there are additional things that are unique to anal cancer survivors in terms of what sort of follow-up you need. So these are the sorts of things that are included in a survivorship care plan. One, on the bottom here, I've got routine screening for other cancers, but it's not just routine screening for other cancers, it's just routine health care. It's going back to your primary care doctor and taking care of all of the other healthcare issues and screening and monitoring that people need to do as they're aging in their lives. The other things that go into the care plan is how you're doing physically, both the late and the long-term effects of cancer and treatment. How is your emotional and mental health? What about fatigue? They often say that fatigue, it takes a very long time to get to previous levels of functioning in terms of energy, and some people it's really hard to get back because of the treatment and because of the disease. There are other things related to toxicities, related to finances, related to insurance, related to going back to work or going back to school, depending on what you were doing before you got the diagnosis of cancer. There's ways in which the employers might expect you might be able to get your leave, your medical leave, your family medical leave, and be able to take some time off while you're undergoing treatment, and then the expectation that you come back to work and you're functioning at the same level as you were functioning before your diagnosis. So there's so many issues that are part of survivorship care. What about all the lifestyle changes? And then what I said already, just the general health related to previous cancer diagnosis. And this is all, again, part of a survivorship care plan. This doesn't, I haven't included on here, just general medical things, that the medical follow-up that you need for surveillance after you've had a diagnosis of anal cancer. And now I'm going to spend just a couple minutes before I turn the presentation over to Emily to just share with you some of the plethora of resources that are available for cancer patients. And I actually was at an oncology nursing conference this weekend, and some of these organizations are new to me. I just learned about. And I know that the ones that are on here, the HPV Cancers Alliance, the Anal Cancer Foundation, the Farrah Fawcett Foundation, and Ian's, all of those you're familiar with because I took those right off of the flyer. So that's something that you probably learn about when you're in the anal cancer community. You learn about those resources. But I was really surprised to learn about some of these things. And for example, the American Cancer Society, which I've heard of, they have a lot of patient and survivor information. One of the other things, and I'm not even talking about resources just when you're done with treatment, but you can use some of these resources when you're undergoing treatment. The American Cancer Society also has some transportation assistance and lodging assistance. Now, that doesn't mean that every community has access to all of these resources, but if you need to tap into these resources, you might need to do a little research for your particular community. Cancer Nation is it's free emotional and practical support. It's something that it's staffed by oncology social workers, actually. I love social workers. I love to have social workers on my team. What they also do, some of these nonprofits, that's one of the nonprofits, they actually have some direct financial assistance. You still need to go through the rigmarole and the applications and all of that, but the specialists at that organization will give you guidance in how to possibly obtain some of the financial assistance. And one of the things that was really special about Cancer Nation is they also have a pet assistance program, which I thought was really cool. I hadn't heard about that in terms of helping people care for their pets when they are unable to care for them because they have to travel for treatment or because you're too sick from treatment. Another big group that is available in many, many communities are what's called the cancer support community. And they do a lot of patient navigation and education. The last two on here, the triage cancer and the wheelhouse cancer. The triage cancer is really special because they are able to help you with things like health insurance, and they're specialists in employment law. So these are really salient issues for people who are undergoing treatment for cancer and sometimes even post-treatment. And then Wheelhouse is a benefits management platform which helps employees navigate cancer. They also have some resources for mental and emotional health, and they also had a really good blog on their site. So those were some really great resources for people who are undergoing cancer treatment or post-treatment. And then a few more resources. One is Commonweal. Well, what I liked about these resources, not the UCSF Mary Center for Education and Palliative Care at Mount Zion. That one is a plug for the work that I do. As you'll see a little bit later in the talk, I'm talking about advanced healthcare directives. Through the Mary Center, we offer free classes for people to actually complete or update their advanced care plans. So I put that on here as a resource. They also have lots and lots of other resources that are mostly free. They do an excellent work. They do an excellent group of classes for caregivers of people with cancer or other neurologic illnesses as well. So that's a plug for my institution. And then the other things on here, the EPIC experience, the real recovery, and the live by living, these are for when you need to get out, you need to get away, you need to do things that are set up for cancer patients, except for the EPIC experiences. They do free adventure trips in Colorado for people at any point in their trajectory. And that can be hiking trips, that can be whitewater rafting. It's very cool. I know some people who have participated in those experiences. Real Recovery is they do fly fishing trips for men who are, I don't know why they don't do them for women, but right now they only do them for men who are cancer patients or cancer survivors. The Live by Living, they have a lot of online classes about mindfulness and Pilates and things like that. And they also have free retreats. A lot of the retreats are out in the West Coast, not the West Coast, in like Montana and Colorado. And the ones that have these free retreats will often help pay for transportation so that all of the costs there, so that the patient has no costs to participate in these things. And then Commonweal also has a lot of retreats. They're not free. That's one of the downsides of them, but they've got some really great retreats here on the West Coast and other educational programs. So I think it's really great to have all of these resources. The one thing that I learned at this conference the other day was some of the, there's many nonprofits out there that can find pockets of financial support for people with serious illness. So sometimes it does take a social worker or somebody else to help you find the resources, but for those of you who might be facing those sorts of toxicities in your care, there are some resources out there for you. So that is where I'm going to stop for now. And
Hi, everyone. I think it's my turn for a little
yes,
bit.
I'm going to turn the program to Emily.
All right, let's see. Technology and I don't always get along, so let me see here. All right. Is everyone looking at my first slide? Donna, are you looking at my first slide?
Yes.
Okay, thank you. And can everyone hear me okay?
You might want to put it on full screen.
It's not on full screen. How do I do that?
With the green button in the corner?
We can see it okay.
Okay, all
Yeah,
right.
it's fine. It's fine. And we can hear you fine, Emily.
Okay, let me just try 1 minute for the full screen. I think technology is going to get me for this one. So just a bit of further introduction and context for me. So when I was making this slideshow, I looked at this slide of the OR and I was like, thinking about whether it would be better. VCU has a number of different slide templates, and I could have put a building or a helicopter or a number of different things, but I really wanted to be specific in sharing that this isn't, my perspective is not the perspective of sort of general physicians. It's a very specific perspective. I'm a colon and rectal surgeon. I now do exclusively proctology, which means outpatient anal rectal surgery. So I see quite a number of patients with anal dysplasia and cancer. I also am fellowship trained and board certified in hospice and palliative care. And I will say that one of the primary motivating factors that led me to do the fellowship was very early on in my practice caring for a woman with anal cancer named Rebecca, who was a very hardworking woman with children, and she was working as a waitress. And so when she developed what became a very advanced anal cancer, rather than seeking medical attention, she put over-the-counter hemorrhoid cream on the cancer for, I want to say, probably over a year until it became very advanced and locally very difficult to treat. And she ultimately had quite a bit of suffering and symptoms related to this advanced anal cancer that were hard to care for. And at the time, due to my husband's military commitment, I was in a small community hospital in Eastern Virginia, and there just weren't resources, and I really felt overwhelmed in trying to help her and very limited in my knowledge and expertise. And it drove me to feel that I really wanted to become more expert and more able to relieve the kind of suffering that I saw this woman experience. So I just wanted to start by asking the group to reflect on whether you've ever left a clinic visit with a clinician with unanswered questions, and to ask you to make a mental note of what the question was or what the questions were. And of note, it's important to remember that it doesn't mean you didn't ask the question, it just means the questions weren't answered. And in fact, I had this experience myself because one weird thing is when you're a woman that does colonoscopy, our hands are too small to work the dials. That's probably too much information. But anyway, you do a lot of twerking with your right hand, and that resulted in my need to have carpal tunnel surgery a couple years ago. And I'm here in the South. My surgeon had the name of a Southern general that he was like the fifth with this name. And I wanted to know what my limitations were from the surgery, especially as a surgeon. This was my right hand. And he told me, use common sense. And I was like, okay, I'll use common sense. And I just kind of slunk away without asking any more. It was really pretty disheartening. Because I had this complete absence of information and I didn't feel empowered to be assertive enough to really get down to the nitty-gritty. So I was like, common sense, I guess I can go to work tomorrow. I didn't operate on anybody. I took time off from that, but I went to work and did rounds and all of that. And so one of the main things I thought I could potentially, in this short time we have together, something of value I could maybe give to the group is to help empower you or to help share the importance of asking questions of your clinician and some ideas about that. And one thing that I think is important to understand, and the context of this is particularly in serious illness and times of difficult prognosis and potentially even very limited prognosis, people, whether or not you as a patient or a caregiver want to know about your own or your loved one's prognosis and maybe how much time they might have left. And this is a question that oftentimes clinicians try to avoid. And if you yourself don't want to know the answer to this question, that's fine. I'm not saying you have to want to know the answer, but if you want to know the answer, a way to approach this potentially is to ask them to provide you information in terms of different phases. For example, is time going to be measured in minutes? That's unlikely, but can happen hours, days, weeks, or months. And it's important to remember too that even under the best of circumstances, clinicians are often inaccurate. And interestingly, when I did my palliative care fellowship, one thing I learned is that clinicians are oftentimes actually very much wrong in terms of thinking that prognosis is going to be far shorter than it actually is. And that is, I think, sometimes from clinicians' fear of a discomfort with the end of life or dying process. But what they don't always understand is that sometimes being wrong on that side of the scale is equally difficult for patients and families as being wrong on thinking that there's more time than there really is. So at any rate, what I want to just say is that it's okay to ask this question, and you have to understand that the answer is not always correct, but it's something that's okay to ask and advocate for getting an answer to. The other thing I wanted to talk about is just this paradigm that we see overall in the healthcare landscape, which is that in general, people tend to say that when they describe what they would say is a good death, nobody describes, or very few people describe being in an ICU on a ventilator, being supported by multiple pressors. But that is not unlikely to be the scenario that ends up happening. And how does this happen? I have had the privilege of working with a woman named Gretchen Schwartzy, who's a vascular surgeon in Wisconsin, at the University of Wisconsin. She's the person that's led the development of the communications curriculum for surgery residents that I've been a part of. she has an amazing ability to put words to different features of healthcare dynamics. And so another thing I thought that might be of value to talk about is this notion of clinical momentum. And this is the idea that there's this basically, and she looks to anthropology and many other sciences to come up with these ways of understanding the behavior of individuals and also greater populations within healthcare. But clinical momentum basically speaks to the fact that as somebody is becoming increasingly ill, there's a pattern that develops that leads to increasingly invasive interventions. And she uses some business terms to describe this, including the concept of sunk costs, which is on the left, you can see this defined if it's not super small for you, but basically like if you invest in starting off a trial or a intervention that's invasive and recovery oriented, that investment makes it hard for the clinical team to then choose another path, which is why the idea of time limited trials is very important in palliative care. So it's okay to try something somewhat heroic, but we're going to set a limitation on this. We're not going to do it forever in the context of a very bleak prognosis. And then the other thing is cascade effects, which is basically once something happens, you're triggering like multiple other interventions to flow from it. And some of this comes from the way clinicians, including myself at times, tend to perceive the sort of decline of a seriously ill person as being a result of complications of our own procedures or decisions rather than the illness progressing itself. And so we want to fix or make right things that have happened. And the next slide sort of depicts this, that somebody comes into the ICU and they, for example, get intubated and they get diagnosed with kidney failure, and basically this whole sort of series of somewhat overwhelming interventions start taking place, and sort of before anyone really realizes what has happened, the patient has a tracheostomy, which is a somewhat difficult to reverse decision, and that somewhat commits them to sort of prolonged aggressive care. Not necessarily always, but this is sort of the way things can happen, and people end up getting care that may not be consistent with their wishes in terms of end-of-life care. But I think I do want to stop and just make the point, though, too, that palliative care is neutral towards invasive, aggressive intervention oriented care versus allowing a natural death. The goal of palliative care is to help support patients and families in making decisions that are aligned with their preferences. So I fear that maybe I've focused or emphasized more the idea of not doing aggressive care, but there have been instances where, as a palliative care consultant, I've argued with a team to say that a patient really wants to be on a ventilator, although we as clinicians may feel that that's unlikely to have a positive outcome. It's their wish to maintain that level of care, and it's important to recognize and support the patient's values and preferences. So I was kind of noodling along making this talk and looking at various pieces of data that I thought might be interesting to share with you. And what I find interesting, what I want to depict with this map is the variation in admissions to critical care units during a hospitalization in which death occurred. And as you can see, there's quite a bit of geographic variation between this event. But what's really interesting is that this shows a paradigm that's really kind of unique to modern healthcare, in that we're providing this really aggressive care to people. And then, generally, if someone's in an ICU, more often than not, it's going to be very difficult for them to make their own healthcare decisions. And then we're basically often requiring a patient's family to then sort of renounce this care or decide against this care, because the data also shows that people generally or often do not die in ICU. So there's this transition that we're requiring patients and families to deliberately make, which is very unique to the current healthcare environment. So another thing I wanted to share, this is a paradigm that I came up with in another context, but I find it to be useful to help people understand physicians and surgeons, because one of the things that I thought I could also bring to you is just to help better understand the people that you are dealing with as clinicians. So as physicians, we have brains, which is great for healthcare decision-making, accountability, but at times that can lead us to be arrogant and not always understand the values of our patients. We have tremendous caring and empathy, but sometimes that can lead us to be overly aggressive because we so desperately want our patients to recover. And then the hands of a physician stand for or represent activation and the need to do things to make things better, the fix-it paradigm. So what can we do? Be prepared with a list of questions, understand your own intentions. If you're not asking questions, do so deliberately, not passively. Have an advocate and make sure your advocate understands your own wishes. And then lastly, this is again from Gretchen's work. And she describes this specifically in the context of surgery, but I think it applies to all of healthcare really. And I know Donna is going to go into this topic in much more detail in the context of values. But if we think of healthcare interventions as potentially offering four possible goals, I think it can be helpful in thinking through what the aims of different interventions are. And basically the aims are to live longer, feel better, prevent disability, or make a diagnosis. And if a healthcare intervention is not serving one of these four goals, I think it is appropriate to question its benefits. So I would just ask you to reflect if you think you maybe are better at getting a tough question answered. And I know Donna is going to take over here and share a lot of very helpful information about values and advanced care planning. I just wanted to thank the group for the opportunity to speak tonight. It's been a really tremendous experience to get to know Donna and learn from her expertise and work with her in coordinating the sections of this talk, and to get to know Mary Jo a little bit better, who has been a great person to provide a patient's perspective in some of the work I've been doing. Thank you.
You're muted, Donna. Okay.
Unmute. I should know after 5 years on Zoom how to unmute. Wait, I am not on the right slide. Okay. We're going to switch now and talk a bit about advanced care planning and values-based decision-making around end of life. I love this cartoon. You know, a lot of people like to put off end of life decisions because it's an unpleasant topic. Good for you, Rat. What have you decided? I will be avoiding death altogether. Well, that just is not true. This is from The Onion, but it is a fact that 100% of people who are living will die. Okay, what is an advance directive for healthcare? Being most people, especially if they've been through treatment, surgery, anything, you do have an advance directive for healthcare. I'm not going to go into this too much into detail about what it is, but the thing that I want to point up, two things I want to point up. One is guiding the decision makers and understanding your wishes, beliefs, values, and priorities. Because as Emily was just saying, you might not be in the situation, you might, An advance directive will only come into use if you cannot be making decisions for yourself. Somebody has to make them on your behalf. I say decision makers, it could be a family member. I'm not going to go into it here either, but somebody in your family might not be the person that can advocate for you in the best. But so once you've identified your decision maker, it has to be somebody who you know could advocate for you. And wishes need to be kept up to date. In other words, if you've done an advance directive and it's been longer than 5 years, take a look at it. Make sure that the things that you wished for before are still the same things that you wish for now. Also be aware that if you've had a serious diagnosis or a change in your mental status, or somebody in your family, your decision maker has changed, you need to review it. Why is it important to have an advance directive? You never know when a medical emergency might happen. Again, it's an important way to ensure that your wishes for healthcare are honored. We try and honor them to the best of our ability. And also, if you've had the discussions and you've talked to your family about what your wishes are, if they're in that horrible situation that Emily was just describing about, where constantly you need to make decisions to start or stop treatment, if you've had the discussions and they understand what is underlying some of those values, under what conditions would you not want to be kept alive, have any kind of life-supporting treatment, this can all be discussed ahead of time. Again, you don't necessarily know the exact scenario that's going to happen. None of us know the exact scenario that's going to happen. But to have a sense of what it might be or how your life might look is really important. These are just some samples there are a gazillion different advance directive forms. The one that we use that I'm teach about is often Prepare for Your Care, which is the one on the left. This is an example of the California one, but whatever state you're in, there's a drop-down menu. It comes in many, many different languages. It's really simple to follow, and it really addresses a lot of the values underlying your choices. It talks about what treatments you may want to start or stop under what circumstances. It also talks about the time parameters. I'm willing to try this for 2 weeks, or I'm not willing to try this under any circumstances, or I want this no matter what. And it does include it in there. There are other things, and this is just, again, this is a whole bunch of different samples of advanced healthcare directives. They all have things that are better or worse. It doesn't matter what form you use. You can use whatever form you want, as long as it is signed, and depending on your state, check your state regulations, whether or not you need to have it notarized and things like that. There's also things that are specific for dementia, for potential dementia. And it always seems too soon until it's too late. You don't want to be in a critical situation and have to have your family or your decision makers making decisions on your behalf. Let's see. Okay. So this is from a book, a book that I've just recently learned about that's called Hope for the Best, Plan for the Rest. That's actually the name for the book, and Winemaker and So are two palliative care physicians in Canada, and they have this whole framework for how to navigate situations in a life-changing diagnosis. And one of the things that I really like about them, and Emily talked about this a bit, was they talk about how to be informed and giving you being empowered as a patient to be informed, to ask questions. But they also say, if you don't want to ask the questions, that's okay. But to make sure that there's somebody on your crew, they call it a crew, which I really like that terminology also, somebody on your crew, the people who are helping you manage and navigate, if you're lucky to have those people who are helping you to navigate your situation, make sure, if you're not the one that gets that information, that there is somebody that has been designated to be the getter of the information. whether that's about prognosis, whether that's about treatment options, whether that's about post-treatment care and things like that. And this is also from their work, from the Hope for the Best Plan for the Rest. They also have the Waiting Room Revolution. It ties into, I mean, Emily started her slides with, how often have you left the doctor's appointment, and wish you would have asked a question. The Waiting Room Revolution is a podcast. It's actually got dozens of episodes at this point, but the first season of it talks about these keys for navigating a life-changing diagnosis. I highly recommend it. I've been listening to it and I've been reading the book, and it's just in a very non-specific way. It's subtly shifted how I think about working with people who are facing serious illness and the ends of their lives. When planning ahead does not mean you are giving into your disease. Speaking about negative outcomes does not increase the odds that it will happen, but it's important to think about it and look at. There's no need to say everything that matters in one conversation. You can start talking and then keep talking. So these are the things that I want you to think about when you're thinking about these discussions with your loved ones, with your crew, if you're working on an advance directive, to think about your own personal, cultural, and spiritual beliefs about this. What matters in your life? What are things that bring you joy? Whoopsie, these slides are going on their own. I don't want that one yet, sorry. What are you looking forward to the most? What are you afraid of? What are the experiences that you've had with someone who is seriously ill? And what would a good day look like for you, even if your health is declining? It's different for every single person. And it's more than just what treatment you want or what treatment you don't want, but what makes your what gives your life quality? Are you thinking about quality of life versus possibly how long you live? And for some people, it's really clear. If I can't do the things that I love to do, I'm okay if my life will be ending. Nobody wants to die. In my experience, people don't want to go, but maybe they're suffering and they can't stay any longer. Okay, I'm going to spend just a minute on this slide. I have a whole stack of party games. Now, this might not be your type of party game, but I really like talking to people about their values around how they want to live. And this is the Go Wish game. It's you can see the link on here, and these are the cards. It's 36 cards that have these different values on them. And I've used these a lot with the patients that I work with as they're either doing advanced care planning or thinking about how they want to live. And I'm sure that if we asked you what would be your 10 highest priorities on here, and there's 20 people on the call, well, right now there's 15 people on the call, we would all have a different point of view about what we think is the most important. And I've used these and they've been really useful, and they change over time with somebody as they're moving through the trajectory of illness, either to being done with treatment and going on to live, or if they're moving towards death. And you can do this online, and every statement will come up, and you can put it in the, something important, very important to you, something moderately important to you, and something not important to you. And I love the Go Wish game, and I take this pack with me wherever I go. I've used it when I've gone on trips. I've used it with a group of people that I travel with, and it's been really informative to have discussions about it. And I've got a whole bunch of other games too. Reach out to me if you want to learn more about some of the party games I have. So I just want to end my talk today with saying that death is not a medical event, it's a human experience. How do you want to live until you die? And as we started with the Dia de los Muertos, the Day of the Dead, again, the Day of the Dead, it's not a somber holiday, but a vibrant invitation to remember that life and death are part of the same circle. Death is acknowledged, but it is not feared. Instead, it becomes a teacher reminding us to cherish the sweetness of being alive. This is a great reference on here. And then this here in this picture, this is my family. On the left, I've got my parents on the left and my in-laws on the right, and they are together, the 4 grandparents, with my daughter in 1991. All of these people are now gone. They are my ancestors. They are the people that I am remembering, and they're holding my daughter. The picture on the right is my daughter's daughter, Eva. She is 10 months old, and this is her Halloween costume. These are the things that give my life quality. These are the people that give my life quality.
Those are amazing photos.
And my daughter was really, really pleased with her daughter's costume because she lives on the East Coast, but we're from California. So Eva is dressed up as a hippie.
Absolutely.
So, and I'm going to end with that. If you want information or know how to reach me, there's my contact information. There's a QR code for my website if you're interested. And I'm going to end my slides and open it up to questions.
Thank you, both of you. Oh my God, I feel like it's hard to talk because I feel like I was going to cry several times during that. It was beautiful. I love that Emily tells us, has that point of view of the doctor that most people don't realize is there, and how much you're doing to help other physicians understand what they're dealing with and what patients are dealing with. What was the quote you said, that death is not a medical event? It's somebody just wrote this in the chat.
Death is not a medical event. It is a human experience.
Wow. Does anyone want to share in the chat maybe some of what their diagnosis brought up for them in terms of their values? That's or anything you'd like to ask. That was one of my thoughts. Or you could unmute if you want to say it.
It's a big topic.
It is a big topic. I just remember when I was diagnosed, I within seconds identified 3 things that were important to me, and it was shocking to me that it happened so quickly, and that I understood so quickly what my values were. And I can't say I would have defined it if you'd asked me on any other day, but that particular moment, it was right in front of me.
What were would you be willing to share what those were?
Yeah, sure. The first one was I have things to do, and it had to do with my writing, my art, the creative things that I do, but I'd put off. My children need me. They were in their 20s at the time. And maybe I won't live as long as my mother, who at the time was 92. So I just had this sense of a clock ticking, and I needed to get on with it. And that was what I experienced.
There was a question about the geographic map that I showed, which was showing the rates of people being admitted to the ICU in their last 6 months of life. And basically the upshot of that was just to show there's a lot of geographic variation, and a lot of people are being admitted to the ICU in their last 6 months of life. And in my mind, the significance of that is just that somebody has to decide then to either not readmit them back to the ICU or to transfer them out of the ICU. And that's a big decision. So that was basically the the point of that slide.
So did that slide actually show that the rates are highest in California?
I'd have to look at it again. I believe they were low in California, but let me
They
let me
were
verify.
they were red in California.
Oh, then they were high in California.
Okay.
That's surprising,
Interesting, huh?
surprising.
Yeah, it surprises me too. Anybody? We lost our psychologist who was here. I wanted to ask him some questions about, but he had to leave. So, but anybody else have anything they'd like to share? Or I would like to do something like this again. So if this topic was useful, please let us know, because I think this is, I mean, with our patient seminars, we talk about sex and we talk about just about everything. So I thought this was one of the topics we hadn't approached yet, and it felt important to me and to everyone else too, I think. Okay.
Thank you.
Yeah, so thank you. I'm so I'm just pleased it went very smoothly, and we've got 3 extra minutes. So we were talking before about the joy of animals and how they help us. So that's one of the those creatures you can talk to about your values, and they'll probably help you figure it out, but won't make any decisions for you. There you go.
This is Charlie.
Oh, that's great. That's great.
Sweet one.
All right. Well, this was lovely, and thank you, and I appreciate it, and your time and the great planning you two did. That was just went so smoothly. So I want to thank everyone. I want you to, if you think there's anyone who would like to hear this, it will be up on the IANS site to be looked at, and there's other patient seminars from the past. And if you have ideas for seminars, please let us know. And I wanted to say hi to Richard because I haven't seen him in a while. So hi, Richard.
Yeah, and please reach out to me if you have any questions or want to do any more work on this. And if you want to do an advanced directive, let me know.
Okay. All
Thank
right.
you.
Thank you all.